All right. Thank you, Dr. Zhang, for that introduction and for the invitation to speak with you today. This is my disclosure. I'm a consultant with the Verfin, but none of what I'm talking about today is going to be relevant to that. Today, I would like you to come away being able to define the scope of clinical informatics, to list applications of clinical informatics in pathology, and to identify opportunities for pathologists to demonstrate value to the healthcare system using clinical informatics. And I'd like to start with perhaps a way not to do clinical informatics in pathology, which is through EPIC, of course. So a while back, EPIC developed what they called a sepsis model, which is more or less a machine learning predictor aimed at predicting whether a patient, typically in the ER, may be progressing towards sepsis based on multiple factors, which includes lab tests as well as perhaps vital signs and other things. What does this do? This can potentially be used to drive what they call a best practice alert, or other interruptive alerts that could send communication to clinicians explaining that maybe it's time to increase care on this patient with to mitigate the risk of sepsis. Sounds good, and certainly something that the company has advertised heavily. However, investigators from Michigan decided to do an independent study of the performance of this alert, and they looked at, the alert was silent, but they looked at almost 40,000 admissions, looked at patients that were ultimately diagnosed with sepsis, and looked at whether the alert would have actually picked up those patients accurately. So these are the results in the chart. You can see which ones the model predicted would have sepsis versus whether the actual, by their definition, by the clinical definition, had sepsis. And if you know how receiver operating curves work, you would know that 0.5 basically defines a garbage test, and 1 would be a perfect test, and so 0.63 is not that great. It's also quite relevant here, much lower than what was stated by or advertised by EPIC. When you look into the details, you could see that it was only able to identify about 7% of patients who did not receive timely antibiotics. That itself wouldn't be too bad. I mean, it would be nice to identify more patients who should have been treated sooner, but the real problem is it created it missed a lot of patients, 67 patients with sepsis, and it created a lot of false positives, which had the providers acted on would have resulted in unnecessary workup and likely would have eventually bugged the clinicians enough that they would stop listening to the alert altogether. So the outcome here was not very promising for this model. And the conclusions that the study came up with were, first of all, the alerts driven by this model reflect the presence of sepsis that was already clear to the clinicians. They would need to evaluate 15 patients to identify a single patient with eventual sepsis. So this creates a large burden of alert fatigue. In other words, if you get 14 useless alerts, you are likely going to stop listening to the 15th alert. So the value of the alert itself is not high. And then finally, they also mentioned that these models, which are based not really artificial intelligence, but based on machine learning, and are proprietary, are sometimes difficult to assess. It's unclear. It would be difficult to really find out what aspects of the predictor could be improved to make the alert actually work. And so you're left with either use it or not, and in a situation like this, given that evidence, most people probably wouldn't use it. So the lessons learned from this are that healthcare systems invest considerable capital into information systems. Purchasing an EHR is possibly $1 billion purchase on its own, just for a large academic center, in addition to, of course, millions in maintenance costs. With all businesses, the vendors overpromise, the healthcare systems expect more than what is likely going to occur, and so you have this gap. And how do we fill this gap? Unfortunately, this vacuum demands clinical informatics expertise to guide effective use, and while that vacuum is slowly being filled, it is going to take some time to get there. So my basic thesis here is we need more expertise in clinical informatics, both at the system level as well as within pathology. So I'll begin very briefly describing what is clinical informatics. It can be defined as the application of information technology and human resources in converting data into meaningful healthcare improvement. I want to highlight there are really two big components here: information technology and human resources. Clinical informaticians are often assumed to just be people who want to work with computers or work with numbers. That is not reality, and some of the people here in this audience would agree with that. The human aspect, that human component, managing people, managing their motivations, managing their interests, all to come to some endpoint that improves patient care, is just as, if not more difficult than the information technology component of it. Some of the components or some of the tasks that we do in clinical informatics are to assess the information and knowledge needs of the system, to characterize and refine clinical processes, to develop clinical decision support systems, and finally, of course, lead in the management and continuous improvement of clinical information systems. I want to start with a few terms that I tossed out there without defining: data, information, and knowledge, which may seem rather vague, but in clinical informatics are fairly well defined. And if anyone is interested where these may have come from, the use of this term, I go back to T.S. Eliot, who is a poet famous for growing up in St. Louis. And he wrote this back in 1934. "Where is the life we have lost in living? Where is the wisdom we have lost in knowledge? Where is the knowledge we have lost in information?" Obviously, he is not an informatician, nor a physician, but I think that you can gather from this statement that wisdom is something greater than knowledge, and knowledge is something greater than information. This leads you to some kind of hierarchy or axis, which some of us would consider the same way that there's a central dogma of DNA to RNA to protein, to think of this in clinical informatics as data to information to knowledge. Data are observations that are not necessarily connected or ordered in any way. Information is data plus some kind of clinical context that puts it together, and then knowledge is information with some kind of application, some purpose, some direction. As an example, if I just gave you the number 6.5%, what is that? That's an example of data. It means nothing by itself. But if you say that this is a result on a hemoglobin A1C test, on a particular patient on this date, and that the reference range is less than 5.7, now you know more, you have context, so now you have information. Then finally, knowing that this is an abnormal result, what do we want to do? Well, we want somebody to act on it. So we could send an alert to a care provider through the electronic health record, and now we have action, we have some kind of application, and so this is knowledge. So I'll refer back to this as we go through a lot of examples of how the daily work of a clinical informatician is to convert data to information and ultimately to knowledge. And I'll mention, since T.S. Eliot mentioned as well, some people will add a fourth element at the very end, which is wisdom, which is as we develop all this knowledge and we see it working, we develop a core understanding of the value of the data that ultimately came from that, and we can call that wisdom. All right, so as I was working in my career developing more of an informatics focus, I've taken on several of these tasks. I'm going to throw out two of these because I think they're fun, sort of quick wins, and then I'll talk more about the longer slog. This is a clinical improvement for transfusion orders. We've, as I've mentioned in some of the discussions I've had with faculty today, we often focus on the indication for transfusion, and that is useful. But trying to convince someone not to transfuse blood when the hemoglobin is 7.1 and waiting until it's 6.9 is often a fruitless endeavor. But another area that is a good target would be the fact that we order, that frequently the default order in some people's minds is 2 units instead of 1. This is nothing new. Multiple organizations have attempted this, but I wanted to see how I could improve, how I could reduce the 2 unit orders to 1 with minimal effort. And so I just made a few changes to the system. Instead of letting people order however many units they want right off the bat, we only have one quick button. It's 1 unit, and it's defaulted. So in order to, there's nothing preventing them from ordering more units, but it's extra steps. They have to go into this space, update it. Pretty simple. And then additionally, we provided an alert. This was right around the time of COVID, so there was good leverage to do it. It was a good time to do it. And you can read this yourself. It feels a little passive aggressive to me, or at least like a guilt trip to get people to change behavior. But it is an alert. Doesn't stop them. They just have to acknowledge it and say, oh, I still want the 2 units. So of these 2 changes, which do you think was the more successful one? The first one, simpler, and it relies on something called the default effect, which is if you don't give people a choice right away, they're likely to pick whatever you've selected for them. The first thing is, it was very successful. I don't even need to really point out to you where the change occurred. That's pretty obvious. So 2 unit orders dropped considerably. 1 unit orders increased in exchange. It does look like it went down and came back up, but this is right in the middle of the COVID pandemic. So this reflects the increase back to more surgeries. However, the important thing is that it didn't go back up to where it was before. If you split it out by specialties, you could see that, not surprisingly, the cardiac ICU didn't change their practice very much. They do a lot of high volume transfusions for patients with severe bleeding. I'm not really concerned about that. What I was really impressed by was how oncology went basically to 0. And it's a demonstration of the very rigid treatment regimens that oncology has developed, which are a 2-edged sword. They could either be really bad if they're designed badly, or incredibly successful if you speak with the oncologist and convince them that this is valuable. So that's a good demonstration of that as well. The other thing that I thought was very interesting about this is that we did have more people triggering the alerts, but more of those people were overriding the alerts as well. We had a drop in the acceptance rates of the alerts. So this really does, to me, demonstrate that the alerts were probably somewhat helpful, but that was not the big effect. It was really that default effect that did it. Separate issue, around the same time during the COVID pandemic, one of our primary tube supplier told us, by the way, we're not going to send you your giant order for blue top tubes this weekend and don't expect it for several weeks. So we were caught rather flat-footed on that. How are we going to support all the coag testing that we're normally used to doing? And so I thought I would just try again, based on what I've learned from the default effect and from just the idea of doing very quick messages. Can we do something very fast for this? So we put in a really simple statement: due to collection tube shortage, do not order PT. PTT is a screening test on patients without a current presentation of bleeding or a history of bleeding disorder. And we also did a duplicate alert for the sake of it, and even says, do not order this as a daily lab on patients. And again, maybe one will work, maybe the other. I didn't have a lot of faith, but I was very surprised by how a very simple, straightforward message was taken by the clinicians. It was not a prohibition. It was not something that would trigger their reverse psychology. It was simply, please don't do this, and here's why. And it turned out quite successful. So when we announced to the hospital that we needed to cut use, we did see some drop in that. And then when we modified the orders as I described, we got even more, about a 20%. And that remained pretty stable for quite some time. And I was really shocked how just a simple change like that could change behavior. And I think that's a big lesson to me. We often work in clinical informatics on a lot of big projects, but sometimes these little, small, quick wins produce unexpected success and build trust in us that the bigger projects that we want to do can get done. So I see the current state of clinical informatics practice as this is an emerging and promising field with many applications in pathology and, of course, all other specialties. But there's still a problem here, which is it is difficult to account for the value that we produce. So yes, here we seem to have prevented 15% or so of tests. What does that really mean financially? What does that really mean as far as patient safety and patient care go? We as informaticists do not have a fee-for-service line. There's nothing we're doing that we could just bill Medicare for. And our activities are often opaque to clinical services. We often do these things a little bit in the background. So each system has to come up with its own solutions for this. And I want to talk about the solutions we came up with. I will say again, after discussing with some faculty today, I think we have some similarity in the way we do it, as well as the way that you do it here, and I think that helps validate that this is a process in the right direction. So we formed a WashU Pathology Informatics service, not just for our hospital, but for our entire hospital system, BJC Healthcare. It includes a few components that I'll describe in more detail. We have an online request system. We have daily rounds to discuss our issues. We have a large number of governance bodies that give us the authority, not just the authority, but give us that entrance into the other services that allow us to build consensus and not just make this authoritarian. And then, of course, we do a lot of education with our residents, fellows, and even medical students. So this is the request website. So we built this. This is intended to be used by only by our department, but for those clinicians who are interested in changes in lab tests or the way that we use lab tests, we ask them to work with someone in our department to submit a request like this. Pretty simple, asking what they want to address, and here are the main list of requests that we can get. So either a problem with a lab order in Epic or Cerner, which is our information systems, to perhaps request a new lab test or the changes to the way that it's ordered, or to request data from our information systems, again, lab-focused data, or some kind of lab application. And all we really request for them is to describe the problem in SBAR format. You can see what it stands for there. I like to call the SBAR the strategy to block annoying requests. Because if someone is not willing to put in the time to write 4 sentences to explain what they want, I'm not going to put in the time to satisfy their need. And this is from the experience of getting a lot of requests, which is, can you just do this? And I really need to know why you want to do that, because maybe there's a better solution than what you're thinking of that meets your goals better, more efficiently. And so that SBAR format, which has faults, it's not perfect, but it's been quite useful at extracting the information we really need. So as far as the service goes, it involves both people and our data sources. So we have now a lot of faculty and leadership that we've grown in informatics. We have quite a bunch of excellent trainees who are interested in informatics and at different levels of skill regarding the technical components, the programming. I do not believe that programming is strictly necessary to be good at clinical informatics, although that depends on what area of informatics you want to specialize in. And of course, we work with our lab teams in the BJC system itself. As far as data sources go, I think this is similar with a lot of institutions. We have to cobble together a lot of different sources. The EHR that we use itself has some good reporting tools that I use on a day-to-day basis, and those are very powerful for answering questions quickly. We also have our own data warehouse that we have been growing and adding new components to over time. Money, no. So we have the support of our leaders, we have our salaries, and then the time is what we find when we can. So I want to demonstrate that, as nice as it is to have the money to start up, the reality is you're not going to get that at the beginning, and you need to prove your worth before you can get that. This is just an example. This is the kind of request that you can make in an EHR reporting tool in 30 seconds. And this just shows you across all of our hospitals which sites had the most abnormal C. diff test rate. Quite easy and usually pretty intuitive. They run from easy and intuitive but limited to powerful but much more difficult to use, requiring much more technical skill. And it's good to have that balance, because you can decide, you can strategize working through your problems, which method is going to be best applied to the problem at hand. And I also want to give credit to one of our faculty, Dr. Zeidman, for coming up with this idea of Lab 2.0, which is related to how we do quality reporting in our lab. So ordinarily it would be you go into our lab information system, you do a query, get raw data, get a summary report, and then send that down to stakeholders. Stakeholders act on that with a goal of some sort of improvement in practices. Great. An example would be, I'm looking for overuse of C. diff testing. Can you identify that? Here you go. Here's a report. Go to it. The problem with that is it's not continuous. It doesn't create continuous change. And so instead, you could use a service that uses a data warehouse. Again, now we're pulling a data warehouse on a regular basis. We create that data in the summary report. We do the analysis within the report building itself. That gets distributed on a regular basis. And now that can not only create an initial change, but can potentially maintain changes and demonstrate continuous improvement. And again, this is a very good application of the data over here, the information as it's being analyzed, and then the knowledge as it's being used to educate providers or drive clinical decision support tools. So I talked a little bit about the stuff that I've done myself, but I think where I've found the most success, what I'm most proud of, are the accomplishments that my residents and other trainees have done on my service. So I wanted to show a few examples of this, and then again, happy to have a conversation about other avenues where these kind of examples of data to information to knowledge can be applied. So first request is to monitor the effectiveness of C. difficile soft and hard stop alerts. So the requester here was a big group. It was our C. diff infection working group. The issue is our hospital is experiencing an increase in C. diff positive results, which may lead to financial penalties. So oftentimes these problems start with money. We're worried about our hospital losing money, but also deep down, this is a clinical problem as well, because these false positives result in unnecessary antibiotic testing and also increased length of stay, all of which harm patients in the long run. But we had the leverage of the financial penalties to get the interest of hospital leadership. So C. diff testing is not recommended in certain situations, and some of the ones that are pretty well established in the literature include duplicate testing within short periods of time, as well as do not order C. diff on laxatives, which is difficult because it seems like most patients in the hospital are on laxatives at any point in time. We had been presenting these as soft stop alerts in Epic for years, and initially worked probably, and then but we have noticed lagging in that. So what is the feasibility and value of converting these soft stops to hard stops? So what does this mean? A soft stop is something, it is a pop-up alert, but it's something that you can ignore. Maybe you have to click on something, but you can ignore it if needed. Hard stop is something that gets in your way that you cannot move forward with, and I'll show hard stops in just a second. But this is one of our soft stops. This is if you order a C. diff test and the patient had a negative within the past 96 hours, you would get this alert telling you why it's probably not very useful, and defaulting to remove the test, but does give you the ability to order it pretty easily. If you do try to keep it, you are required to explain why, so that's another little blocker. However, people were going through it. We were getting a lot of these, we were triggering a lot of these alerts, particularly these kind of duplicate orders, and shocking number of these alerts on patients on laxatives. You would think that patients on laxatives should not. I think you've explained their diarrhea, but that's just me. We were getting much different alert acceptance rates based on what the trigger was, which was also quite interesting. And again, we see a big failure here. The laxative use, only 13% of those resulted in meaningful change where they actually canceled the alert. So we're doing something, either we're doing something wrong or people aren't listening. The soft stop doesn't seem to be very effective, but one of our residents, Patty Hernandez, pulled this data together and provided the basis to say, yes, I think we've done what we could to see if the soft stop works. I never recommend jumping to hard stop from the very beginning because it's very aggressive and needs some kind of clinical justification. But if you start with a soft stop, you demonstrate it doesn't work, it may be time to move to a hard stop. And so we did that, and we used some valuable advice from one of our faculty members, Victor Brodsky, who implemented something similar at another institution. And instead of a nasty pop-up, which nobody likes, we did something a little bit sneakier. We put in an order question that has to be answered. And we tell you why you're getting the alert. We show you where the previous lab test results are and if the patient's been on laxatives. And the really ingenious part of this is you can't just write in text and say, I want it, and it's done. You have to give a passcode. How do you get that passcode? You have to call the lab, okay? So again, that alone is enough to block a lot of these requests, or at least enough to get people to recognize that this is not the right way to go. The passcode, if you're interested, passcode has a algorithm, very simple algorithm that develops a new passcode every day, and the lab has access to it, and that's it. If you do not put in the correct passcode, you get this nasty alert, and then you're done. You can't proceed with this order. So we did a very quick, after we put it live, we looked at when this activated. It activated in this very short period of time, just 3 weeks. It activated on 23 patients. We had 6 passcodes entered with an acceptance rate of 74%, compared to the 58% with the soft stop. So we've already shown some benefit. I actually would have expected a little bit more based on how hard this is, but it shows the motivation for people to get around these alerts. Fortunately, people have adapted to it, and after 12 weeks, the acceptance continued to increase. So this shows some value of continuing to monitor over time. And then since we did this for the duplicate alerts, we have since also added laxatives, and I won't go into that data, but still a surprising number of people are willing to call the lab to get testing on patients on laxatives. So you can only go so far with these sort of impersonal alerts. Next step is most likely identifying the people who do this the most, pulling them inside and saying, let's figure out where the disconnect is. But again, you start with the data collected on how the soft stop was doing, and you end up at knowledge, some kind of application that changes behavior. All right, request number 2, how often do urinalysis from our ED reflex to culture? So this was a question coming from our microbiology medical director. This came about because our ED specialists requested to change the standing orders that the nurses have to remove our UA with reflex to microscopic and culture and replace with a UA reflex to microscopic. So we had, just very brief background, we have 2 different urinalysis reflexes. One is meant for patients with symptoms of UTI that will do, the macroscopic, the microscopic, and depending on those results, trigger a culture. If we find, for example, a significant number of white cells in the urine. Separate from the UA reflex to microscopic, which does not go to culture. It only looks at macro, and if it's positive, it'll trigger micro. So those are meant for patients in which urinalysis is indicated, but no suspicion for UTI. So this question appears to be, it seems like ED thinks that they're using too much, they're generating too many cultures. And of course, the ED physicians have no interest in following up on those because those results aren't going to come back for a couple days, and by then the patient will no longer be under their care. So the question is, can we, and of course, we get that other financial leverage, which is, these unnecessary cultures ordered on patients who were not symptomatic for a UTI trigger if they're done in patients with catheters in, now they become catheter-associated UTIs, even though they're not really UTIs. It's asymptomatic bacteriuria, and that triggers financial penalties. So we also had the leverage to care about this. So we needed to look at this data. A couple of my residents pulled data out of our just Epic reporting tools, nothing special, and asked the question, how many of these reflexes are ultimately triggering culture? So they started with 13,000 total orders. Of those, about a quarter were the reflex to microscopic and 3/4 were the reflex to microscopic and culture. And then of those, about 22% went on to trigger the rules for culture, and of those, less than half, or a total of 9% of the total, actually had abnormal culture. So it's pretty clear that they were over-ordering and they were not getting a lot of good, useful, positive results. So, and we found out why. We found some order sets that contained different uses of reflexes. We found that the BJH, we were able to change the academic hospital's reflex to the one without the culture as sort of the generic order set selection. But we noticed that the communities were still ordering cultures. But when we look at just BJH, after we reported this data to the requester and they made the changes, you can see there is a significant shift in the percent of the reflexes that were for culture versus microscopic. You can still see a lot of work needs to be done. And I think we'll continue moving in that direction. But again, this data analysis and return of the data to the ED team took a day. It took the residents probably no more than an hour to collect and analyze the data. I wasn't even there. I was out of town, and so it shows how easy it is if you have the right training and the right access to make some significant changes hospital-wide. All right, third one. Is there bias in the ordering of urine drug screens on pregnant women? This was a very serious request that came from our OBGYN partners, particularly one who was very focused on equity in clinical care, and comes with the belief, or not belief, but there's definitely evidence showing that drug screens are being ordered more frequently on black mothers than on white mothers. And so, and they felt that this was leading to a lot of harm because it was triggering a lot of positives for THC, and those had to be reported to Child Protective Services, which would have a obviously huge negative downstream effect on the patient and the family. So the request that OB sent us was they would like an order question added to the test to force the provider to explain why they're ordering the test. I wanted to say before we jumped there, before we jumped to the application, let's look at the data and let's make sure it's what we expect. So this is another one of our residents, Vahid Azimi, who fortunately we've now hired to stay on as faculty. Again, simple reporting tools in our commercial EHR to pull out the orders and then normalize the order rates by race and compare positivity. And it did show, first of all, that black mothers were being drug tested more frequently than white mothers. And it's no contest. You don't need a p-value to see that this is a problem. But what was even more fascinating was if you broke this out by the drug tests that were positive for THC and only THC versus the results that were positive for something else, you can see that yes, there is a higher positivity rate for THC in black mothers, but when you look at the other drugs, it's actually slightly higher or essentially even between the races. So it's clear that whatever is triggering people to order this more frequently in black mothers, it is not coming out with identifying higher rates of the more dangerous drugs. So that does seem to be evidence of a lack of equity. So with that data now equipped, we went ahead and did add this order question, which again requires an indication to be placed for a drug screen on particularly on pregnant women. And you can see some of the examples here for what options there are. We also allowed them to enter free text if they wanted to do it. Not only we're not necessarily hoping that just putting this in there is going to change behavior. Maybe it will a little bit, but what it's really going to do is give us insight into how people are using these tests differently among our different populations, and perhaps then come up with a solution to reduce that gap in equity. And I don't have the data for you here, but I can say that in black mothers, there is a very enriched response for lack of adequate prenatal care. So is that accurate? Is that true? Or is this the pathway to just explain something that you wanted to do anyway? That's our next step. So I think this is a very promising direction for us. So I'm going to go back to those 3 examples and just demonstrate again how this is data to information to knowledge. So with our remember that data into information is basically the collection and analysis of data into something that gives us context. So with the C. diff orders, that's the proving that the soft stop alerts failed. With the UA reflex, that's showing that there is a high rate of order of culture of the culture reflex in ED patients with low culture positivity. And for the UDS in OB, there's that demonstration of a disproportionate rate of orders in black mothers despite a lower apparent yield of more severe drugs. So that's the data to information part. Then the information to knowledge, the actual action, which you could call, in many cases, clinical decision support. So we convert that soft stop to hard stop. We make these updates to the ED orders to include more or emphasize the use of the non-culture reflex. And then finally, you have the order questions that can be that we added to the UDS. And you see this theme over and over as we go through the tickets that we have to our system. And to date, almost 2 years, we've had over 100 requests that are completed. We still have a lot hanging out there, and that's something that we have to work on, and that brings us to the challenges. We have a lot of competing priorities. I cover several clinical services. Our other faculty and other residents have distractions. I shouldn't say distractions. They have clinical care duties that they have to do as well that are also quite important. But there's only so much time we can obviously devote to the informatics side of thing. The building infrastructure is still quite tasking. We sometimes have to rely on external data sources. I call that a challenge. Sometimes there are benefits to using the data resources that are already available to us, but if you don't control the data source or the teams that are necessary to build those requests, you are sometimes at their mercy, and that can really delay things or can bring about confusion in ultimately what they decide to build for you. And then finally, communication with requesters. So when we make these changes, how do we get back? How do we get enough stakeholder engagement? And I hope what you're seeing out of there is that's the human resources part. So there's both the information technology, but that human resources is so critical. So before I get to my conclusions and ask for questions or conversations, I do want to acknowledge the leadership in my department that really supported us creating this informatics service from scratch, essentially. The other faculty in our section and the department as a whole, all of these trainees who often are doing this on their own time. They're on other clinical services, but they choose to spend their time with us and work on these problems because they find them exciting and very rewarding. And then, of course, our lab staff and to all the people that submit SBARs, so that because it's not just it's not just a task to me. It's every time we deal with one of these SBARs, I learned something too. Either I didn't know that this data was stored here in the system, and now I can access it somewhere else, or I didn't know we could actually make this change. We could build the order question this way. Every time we do it, we learn something new, and that's a big part of the excitement that I have on the service. So to conclude, clinical informatics and pathology informatics are disciplines. They are not, I called it service. That's one part of it, but they really are disciplines, educational, they're education, research, clinical care disciplines that improve all aspects of what we do on a daily basis. Accounting for the value of the clinical informatics still remains a challenge. I really like what we do as a service because those tickets get documented, and now I can say, well, what are you doing for us? Well, here you go. But there are other ways to become and remain visible to other departments and to hospital leadership, because that's really where you get the buy-in, where you get the stakeholder engagement in the solutions that you want to make. So there are these metrics to demonstrate value. Of course, publications. There are the tickets that I just mentioned. You could do external surveys of clinical providers of what needs to be addressed. And then we get down to more the hard stuff, so the resources saved or generated. So some of these, as I sort of described, can be converted to money, or some of them can be big ticket, very strategic initiatives. And even if it isn't a number, it's very clear if CMS is penalizing us for our our UTI rates or our C. diff rates, nobody's going to argue with throwing some resources at that to fix it. To conclude, pathology programs are well positioned to address healthcare institutions' informatics needs, data, information, and knowledge. Oh yeah, sorry. Some of you may know I'm originally from Cincinnati, and so I'm very excited, but I didn't have an orange tie, so I wore a purple one instead for all of you. And then finally, the Pathology Informatics Service is a novel way to fulfill these needs and meet the tripart mission of our university, which is clinical research and education. Fortunately, I've ended with enough time to entertain questions and hopefully have a conversation. So again, I want to thank you for inviting me, and happy to keep the conversation going. Thank you. Should I have this open while we're answering questions? Okay, good. Questions? Yeah.
For that list of indications for overriding the drug test, how did you come up with that list?
So that was, there's always a little bit of give and take and identifying, who. Oh, sorry. Let me repeat the question. So for the drug test, who came up with those indications? You want to rely as much as possible on the content experts, of course, and those would be OB. So OB gave the initial list of indications, and then we did a quick pass through, and from a standpoint of someone who's not an OB expert, what makes sense? So we give that first sort of layman's terms kind of understanding, and then the other thing that we do one of the lessons you learn in clinical informatics is concise, cut down. So some of the indications we were originally given were much longer, and we said no one's going to read this. And to be honest, that list itself, I already felt that you had is quite long. There were I forget the number, something like 12 options. That's going to be difficult for a busy clinician to read all the way through. So if you're gonna insist on that many, make them shorter. We did have them combine some of them as well. So that's a little bit of the expertise that we can provide, even though we don't have the content expertise. So it was a combination effort. Yeah, good. Other question, Noah?
Thanks, Ron. That was great. Can you say more about you mentioned a daily rounds. Can you say more about what that is, like who participates, and are they like project oriented, or are they issue oriented, and a little bit more about that?
Yeah, excellent. Yeah, so and it's a little bit has to do with the way I do my leadership. It's less structured than what other people might do. But we set aside an hour every morning, 9:30 to 10:30. And the people that we expect to come, the informatics faculty, and the residents who are either interested in our service or are on an elective, informatics elective. And we also now have an informatics elective for our medical students, so we often have a med student engaged. It's a little loose sometimes, so sometimes I usually lead it, sometimes another one of our faculty leads, and then sometimes I let the residents or fellow, or clinical informatics fellow lead it. And the primary goal is to look at all those uncompleted tickets, start with the new tickets, and then strategize where we want to go with that, look at the uncompleted tickets to see how we're monitoring, and then usually devolve into trivia and nonsense, which is what I do. That keeps it a little light. But the goal there is all about strategy. How do we want to address this? So you ask, is this even a good idea, right? And then we never just shoot it down. There's always going to be a conversation. But is this a good idea? We think about different ways to approach things, and so I remember earlier this week we had there was another request actually for the UDS, and that is to apparently the OB service or on pregnant women, before you can do a UDS, you're required to get consent. I'm not a lawyer, so I don't know the exact rules for that, and so they wanted to add another order question: did you get consent? And so that question, that comes out as, actually they asked for a hard stop. And so I started with, hard stop, soft stop, order question. What are the options here? What are the pros and cons? And in the course of that, I let the residents tell me what they want or what they would think. I give my advice and we kind of settle on where we want to go with that. So there's education there. And then finally, I assign it to a resident. I say, I trust you enough to speak with the clinician on this, get feedback, come back to us, and tomorrow or in 2 days, and that helps keep the project moving, and that's very helpful for me because again, I'm sure you have the same experience. I have probably 50 projects active right now somewhere in the ether, and if I can't keep my eyes fixed on one of them within 2 days, I've forgotten it. And I won't hear about it again until some doctor angrily emails me like, what are you doing about this? So this helps keep us on task every day. Yeah, sorry for that long answer, but yeah.
Hey, there's 2 questions online. Andrew Bryan asks, he says, thanks for the excellent talk. For the enter passcode for C. diff, is that passcode generation with an Epic, the LIS, or a third-party app? And then who within the lab is giving and approving that passcode? Okay, good. Yeah,
good question. So the first question is, how is the passcode generated? It is an internal algorithm that's based on the cache date, which is basically the electronic health record system obviously needs to know what today's date is, so that it's recorded as, I think, the number of days since January 1st, 1841 or something like that. I don't know why they picked that particular number. I think that's James K. Polk, if I recall. That's trivia, sorry. So that's just a giant number. And then I came up with just some simple mathematical operations on it. And then I pull that out as a 4-digit number. And then I don't have to think about it anymore. It'll just keep generating. But also, since I know how to get to it, I can calculate on my own. But there's a report that can generate it too. So it is internal, but we were able to tweak it a little bit. Because obviously, if it's 001, 002 tomorrow, 003, people are going to figure that out pretty quickly. So it's got to be something that's a little unpredictable, but that you can still calculate when you need it. So that's the passcode. And then the other one was, who has it? So who controls the access to the passcode? We had a lot of discussions, and we ultimately decided that it was the customer service, lab customer service, which is the first place where you're going to call the lab anyway. And I can say this here because the WashU doctors aren't listening. We instruct the customer service, don't fight them. Don't demand an explanation. Sometimes the people calling do explain. That's fine. But if all you got to do is call and you will get it. So what we're really testing is the barrier. Is this needing to call enough of a frustration that you're not going to do it? That's the negative way to think about it. The positive way is the fact that you can't proceed makes you stop and think, oh, maybe this isn't important. Whereas before the soft stop is like, oh, just cancel, because people get 100 soft stops a day and they ignore them all. So it's kind of, so I think that process alone was successful. If we want to make it tougher, then we would probably we'll need to convince our information prevention faculty to take that over, or maybe the fellows, yeah.
Then the other question line is how long can it take if an educational comment to be added to a simple order in Epic? So I guess how long is the process going to take to add a simple comment? Okay,
you mean like something in the order, like a instruction in the order?
I think that's what the...
Okay, yeah. The time it takes is really based on the priority, and the priority you give it. So if you say this is dire, this is going to harm patients if we don't fix it, you get that in the next day, right? If you say this is to make things a little easier on the doctor, guess what? That's going to take months if it's ever going to be changed at all, and that's because we have limited resources in LIS, and they need to prioritize. So who does that prioritization? Me. Well, not just me, but the leaders. You need governance leaders that define who can help define that prioritization. I'm not just making these willy-nilly. There may be rubrics for patient safety, regulatory risk, et cetera, that help you define that. Ultimately, at the end of the day, if something really needs to be done quickly, it's up to me to inform the LIS and get them to move faster on it. I would say most urgent things that aren't like actively harming patients but need to be changed really quick, I can usually get them to fix it within a month. And I try to be realistic with people, and if they demand what is pretty clearly just like a convenience improvement, I tell them it's going to take. Don't expect this tomorrow. It's going to take a long while. So just being realistic and being honest with their priorities, and that's where where that human component comes in. Yeah.
So in terms of like the amount of resources that you have with this, are you working with Epic analysts, or is this something where you have kind of physician builders, or how are you getting these changes in?
Yeah, so most of the work is being done by analysts, and we have a unique situation in that the analysts are under the hospital system I'm under WashU, so I don't have that direct ordering connection. My authority, as I mentioned to some people at lunch, is based on persuasion and the atmosphere of authority. It's not an illusion, but that sort of understanding that that I've created enough consensus across the system that I'm not just making stuff up. That I'm really representing the needs of the patients and the physicians. I forgot. It was, oh yeah, all right, so yeah, the analysts are doing most of that work. We do have a physician builder program here. It's at WashU, sorry. It's still fairly new, and it sounds like the physician builders that you have might be your program might have been out there for a little bit longer. But I honestly would not, no matter how educated they are, I would not trust a physician builder to make a change by themselves. So they can mock stuff up in a test environment and then bring that to our analysts. But ultimately, we need the people whose job it is to make it work, because there's so much validation that has to go on that we don't think about. We have to test all the different ways that this process could fail. Because once we put it in there, it is affecting every patient, potentially every patient in the system, and so you need to have a healthy fear of putting in a disaster every time you put in one of these tools. Yeah, good question. Anything else? Yeah.
Yeah. How do you approach rollout of these interventions? Like, I assume they don't just appear overnight. Like, are there educational initiatives, especially with your CDI working group?
Yeah.
You talk to other hospital stakeholders?
Okay, good question. So the question was about how we manage the actual rollout once we decide what to do. Communication, absolutely important. Certainly, you can start by picking the go live date, and we do it every other week. Every other week, we have a specific date where all the changes are going to take place. All the routine changes, emergencies are off cycle. So the people are already primed that this is the date where some changes are going to happen. There is a kind of newsletter that describes all the changes. I am not convinced that many people read that, and that's fine. That's a little bit of CYA. I'm not going to say what that stands for. But the real trick is who cares about this? Who is the stakeholder? Who are the stakeholders? How do I communicate them? And it's going to be different each time, but it's absolutely critical to identify who these stakeholders are, and not just warn them ahead of time. If you involve them in the decision-making process, they will also be your champions and go out and help you. So, I never, to the extent that I can, come up with a decision before I even talk to the people that the decision is going to affect. Sometimes it's sometimes difficult or impossible. If you're making a change to a CBC order, anyone can order that. You're not going to engage the entire hospital. You have to make some kind of reasonable decision. If you can't get the people affected by the decision, you at least engage the people who are content experts. So if it's a CBC, I'll get the HEMONC department and say, does this make sense to you? At least we have some shared responsibility or shared blame, however you want to do it. But communication is absolutely critical for that. Yeah. Any other questions? We're out of time. All right, we're out of time. Sorry about that. Thank you very much.